Today we're going to talk about how we diagnose allergic disorders. Allergies are common, and as nurses we see them everywhere, from primary care offices to emergency rooms. Getting the diagnosis right matters because it guides both treatment and patient safety. When we talk about diagnostic evaluation, we're looking at a mix of lab work, skin testing, and sometimes blood tests that measure immune responses. None of these are perfect on their own, but together they give us a clear picture when combined with a good patient history and physical exam. Let's start with the basics. The complete blood count with differential. In allergic disorders, the total white blood cell count is usually normal unless there's also infection or inflammation. The key piece we look at is the eosinophil count. Normally, eosinophils make up about 2 to 5% of white blood cells. If you see levels above 5 to 10%, that's considered abnormal and often points to an allergic response. Eosinophils can also show up in sputum or nasal secretions during symptomatic episodes, so a smear can give useful information. Next, we look at total serum immunoglobulin E levels. IgE is the antibody most responsible for allergic reactions. Elevated levels don't tell us the exact allergen, but they do support the diagnosis of IgE-mediated allergic disease. Patients with high IgE are usually the ones with asthma, allergic rhinitis, or atopic dermatitis. One of the most important tools is skin testing. This involves placing or injecting small amounts of suspected allergens into the skin to see if a reaction develops. A positive reaction looks like a wheal and flare, basically a raised red, itchy bump surrounded by redness. Skin testing is considered the most accurate confirmation of allergy, but it has to be interpreted carefully in the context of the patient's history and other findings. There are a few safety points to remember. Skin tests should not be done during periods of bronchospasm. We always start with epicutaneous tests, scratch or prick tests, before moving on to intradermal methods because they carry less risk of systemic reaction. Emergency equipment must always be on hand in case the patient goes into anaphylaxis. And medications like corticosteroids and antihistamines can suppress skin reactivity, so they need to be stopped 48 to 96 hours before testing, depending on the drug. When interpreting skin tests, we use a grading system. A negative reaction is basically no wheal with minimal redness. A 1+ reaction is a small wheal around 5 to 8 millimeters with redness. 2+ is 7 to 10 millimeters, 3+ is 9 to 15 millimeters and may include slight pseudopodia, and 4+ is anything over 12 millimeters with pseudopodia and diffuse redness. Remember, though, that false positives can happen if the allergen solution is prepared or administered incorrectly, so results must always be correlated with the patient's history. Now, sometimes skin tests aren't possible or the results are unclear. In those cases, we can turn to Serum-Specific IgE testing, formerly known as RAST. This blood test detects antigen-specific IgE in the serum instead of relying on mast cell reactions in the skin. The advantages are that it avoids the risk of systemic reaction, the antigens are stable, and it isn't affected by medications that suppress skin reactivity. The downsides are that it's less sensitive than intradermal tests, the allergen selection is limited, the results aren't immediate, and it's more expensive. Another option is provocative testing. This involves applying the suspected allergen directly to the target organ, like instilling it into the conjunctiva, nasal passages, or bronchial tree, or having the patient ingest the allergen to see the reaction. This test is only used in very specific circumstances because it carries the risk of triggering severe symptoms such as bronchospasm in patients with asthma. Finally, let's touch on the difference between atopic and non-atopic allergic disorders. Atopy refers to a genetic tendency to develop IgE-mediated responses to common environmental proteins, like pollen or food proteins. Atopic diseases include asthma, allergic rhinitis, and atopic dermatitis, and they often cluster within the same individual or family. Non-atopic disorders don't have this genetic link. A good example is latex allergy, which can show up either as an IgE-mediated anaphylaxis, which is a type 1 reaction, or as a type 4 hypersensitivity known as contact dermatitis. To wrap up, diagnosing allergic disorders relies on a careful combination of history, physical exam, and diagnostic tools. We use CBCs, eosinophil counts, total and specific IgE levels, skin testing, and sometimes provocative testing. Each tool has its strengths and limitations, but when used together, they give us a strong understanding of the patient's allergic status and how best to manage it. That's it for today's lecture on the diagnostic evaluation of allergic disorders.